Welcome to the Immune Edit. I'm Dr. Doug Jones. If your immune system feels like the enemy, or you're just tired of not feeling like yourself, this space is for you. Wonderful to have everyone here today at the Immune Edit. I've got an amazing guest that I've been just from the concept of this podcast, I've had this guest in mind to be able to have on the show, because I think it's going to be such a powerful time for you. We have with us Dr. Adam Fox from London, and I want to welcome him in. I'm going to let him introduce himself in just a minute. We met, was it a year or two ago? I'm losing track of time. I think it was a couple of years ago.
It was a couple of years ago.
Yeah, it was a couple of years ago. I was going to initially say a year ago, but then I'm like, no, it's been longer than that. When I had an opportunity of visiting London and visiting Dr. Fox in his clinic and meeting with his group there, which was an amazing experience for me. And since that time, he and I have been able to collaborate and discuss and share stories. And it's been a wonderful bridge to be able to go across from the United States to the UK and get into Europe and be able to really feel the camaraderie across the pond. So I've really enjoyed our discussions. I think today's going to be so powerful for anyone listening. And just like to welcome in Dr. Adam Fox. Why don't you take a moment and just introduce yourself to the audience and let them know a little bit more about you.
Sure. Well, firstly, Doug, really honored to be here with you. It's always a joy every time we have conversations and interactions and getting to visit you. So thank you. So I'm Adam Fox. I'm a Londoner, born and bred. I'm a professor of paediatric allergy at King's College London. My practice is mainly based at St Thomas's Hospital. That's one of the big London teaching hospitals. Americans always find it surprising when I tell them that we're approaching our 1,000-year anniversary at St Thomas's. Our alumni include people like Florence Nightingale and people who, the Dr. Bright that coined Bright's disease, and Addison who coined Addison's disease, and Hodgkin. All of these guys place of the first ever blood transfusion. So a lot of history there. It's a fabulous place to work. Yeah. I look out my window and I can see Big Ben and the Houses of Parliament. And it's been a real pleasure over the last 20 years. Yes, 20 years this year. It's our anniversary. Myself and colleagues will set up a new paediatric allergy department there that has grown significantly. We're now one of the largest in Europe. But I think our claim to fame is my close colleague and previous boss, Professor Gideon Lack, ran the LEAP study there and the EAT study. So these are the studies that led to real change in global public health advice around allergy prevention. And we saw some lovely research coming out of the States just recently showing just how many people it would have prevented from getting peanut allergy, this change of early introduction of peanut into the infant weaning diet. So it's been I've been blessed with having a really exciting career, being part of research that's really made big changes. But the last 5 to 10 years has also been a big change, because I've been able to enjoy moving our own practice from that very sort of pedestrian and passive involvement of diagnosing food allergy to being part of this revolution of treating food allergy. And, we've seen this incredible change of going from just being able to tell people what they're allergic to and they're going to have to cross their fingers and hope it gets better, to now actually having a whole menu of options that we can offer for them. And, in no small part, Doug, to yourself, because of the pioneering work you've been doing and the way you've inspired a lot of British allergists actually to up our game and start, getting our heads into this whole new way of thinking around food allergies.
That's beautiful. Thank you. I've been thinking over the last little bit, because when you read certain research articles, it talks about this quote unquote emerging therapy, and I'm like, hold on, it's emerged.
Absolutely.
and when I hear emerging, I have this visual of like a baby being birthed, and I'm like, it's not being birthed, it's birthed, it's here, it's emerged. And if you haven't embraced it, you're behind. And it's been awesome.
But Doug, you're talking from an American perspective, and we have a very, very different healthcare system here in the UK, and I think it's probably worth giving a bit of context around that, because
that'd be great.
Yeah, we have a state medical system which we are enormously proud of. So this is something that was born out of the Second World War. People came home from, having really sacrificed an enormous amount to find that the old order was sort of still there, and that if you happened to be poor, your access to healthcare was just rubbish. And if you happened to be wealthy, it was great. And the Harley Street, no idea whether you've heard of that, but it's something that we believe is world famous. But the private medical district of central London has always been sort of at the forefront of medicine, but only for people who can afford it. Now, we can make a particular claim to fame because actually in 1908, a paediatrician by the name of Schofield wrote up in the Lancet the first ever reported case of food OIT, and that
Yeah,
was on Harley Street. That was
right.
he was a private paediatrician working there. So in the late 40s, essentially what the government decided is that they were going to essentially nationalize healthcare. So they were going to convince all of the doctors to stop working privately, but to instead work within a state system that was completely universal. So everybody, every single member of the public would have access to healthcare, full healthcare. Everything from a bone, well, not quite then maybe, but a bone marrow transplant all the way down to fixing a broken finger, free at the point of delivery, completely free. And that included, your medication that you needed, access to maternity services, community-based healthcare, preventative healthcare, everything completely free. And the idea was, because the principle at the time was, if we move away from treatment towards prevention, the population will be so healthy that it will barely cost anything to maintain the health of the nation this way. And of course, fabulous principle in practice couldn't be more wrong. And this has become an increasing spending burden. So, whilst we have a system that is incredibly universal and does have pretty good quality, certainly when it comes to emergency care, the problem is it's creaking under its own weight. So, remarkably, the National Health Service is now the world's third largest employer after the Indian Railways and the Chinese Army. So
Wow.
they are the only organisations bigger than the NHS, has over 1 million employees, and it does a fantastic job in lots of places. But unfortunately, and mainly because of a lack of resource and often actually workforce issues, just a lack of staff, for some areas it doesn't deliver very well. And where it does deliver, it does so very slowly, and there's very long wait times. When you pitch up in an emergency department, you may be waiting hours to be seen, and sadly,
Mhm.
especially in the winter, it's often characterized by lots of elderly people waiting in trolleys in corridors, and can sometimes look like something out of the developing world. So, it has its pluses and its minuses. But I look at it, of course, very specifically through the lens of an allergist. And
Right.
unfortunately, allergy was never a specialty that got a lot of attention within the National Health Service. And part of that's historical because we're a relatively new specialty. We came
Mhm.
along late, so it takes a long time to be accepted as, to get that seat at the table. But also in healthcare systems like the ones in the US, people are able to vote with their feet. If there's a lot of people who want allergy care, there'll be that will lead to the demand being met by more allergy doctors who are providing allergy care. But it doesn't work like that in a state-provided healthcare system. The decisions around where more resource goes come centrally, and allergy has always been struggled to have its voice heard. And as a consequence, for many people with allergies, they just don't get access to specialist care. We've got some pretty shocking statistics that only 10% of people with food allergy will ever see anyone above and beyond their family doctor. And that's despite the fact that we are leading the world, not many things these days, but what we do lead the world in is prevalence of food allergies. And we've seen a trebling of cases of anaphylaxis pitching up in the emergency departments over the last 20 years. We've seen a doubling of cases of food allergy in the last 10 years. So we've got a lot of disease, but we have a tiny number of specialists. And in fact, when I first qualified as a pediatric allergist, and we do pediatric and adult allergies separately in the UK, I was one of about 7 or 8 pediatric allergists for a population of 65 million.
Wow.
So we had less allergists in the UK than you would have in an average US city. And
Yeah.
actually, we didn't compare particularly well to the rest of Europe either. There
Mhm.
were there were certainly far more allergists in places like Finland, Latvia, with populations of maybe 5 or 10 million than there were in the UK. Now we've got a little bit better. There are a few more of us. I think people imagine there's more allergists in the UK because, from a research perspective, maybe we've punched above our weight. There's quite a lot of research output because it's quite an academic specialty. But actually,
Mhm.
on the ground, access to specialist allergy services really, really poor. Now, alongside our National Health Service, which is free for absolutely everybody, there is a private alternative, which people sort of mix and match a little bit. But most of
Mhm.
the people who work, doctors wise, who work in the private sector, typically have one foot in the National Health Service as well. They work in both sectors. So practice is broadly similar. And because of that sort of, our background as a nationalized system, we tend to be very much sort of about not seeing our patients any more than we absolutely have to. And there's a real approach of sort of, do as few tests as you can get away with, and generally just less medicine, which of course, is often a good approach. And
Sure.
certainly around the world, I think the UK approach is often appreciated because of that.
Mhm.
But sometimes it means that there's not the intervention that maybe there could be in terms of, preventing things further down the line. And when it comes to things like allergy, where we know now that there's so much potential benefit of early intervention, when you have a system with very long waiting lists that's hard to access, that is very non-interventional, it doesn't necessarily work that well. So in the private sector, about 7 to 10% of people in the UK will also have private health insurance. And so they will be able to access similar care, but that happens a lot more quickly. And we often say the main real difference between medicine privately in the UK and on the National Health Service is just how quickly you can access it. You'll get
Sure.
the same operation, you'll get the same intervention. Although in allergy, sadly, our National Health Service has struggled with trying to deal with these changes and what's happened around immunotherapy. It's very conservative. It's like turning the oil tank around when you want to make big changes. And so we've got some way to go. So if I remember a
But
long way back ago when you actually asked me the question why we're talking about this, it was just that on our National Health Service, it's still seen as an emerging treatment. And most
sure.
people, even seen in
Yeah.
teaching hospital specialist centres, will not have access to oral immunotherapy.
Yeah, and as you were talking, I was just thinking what you said actually has played out in terms of like your research has punched above the belt because look at the groundbreaking research that you mentioned before, Dr. Gideon Lack and your group started with early introduction of foods and the massive change that has made in the world and changed all of our thinking about how to approach early introduction of foods. Yet that comes within in the UK in particular in a system where those first few months are critical to get the early
Yeah,
introduction of foods, and
absolutely.
patients may not even have access to the doctor to be able to do it.
Yeah.
There.
Yeah. And the crazy thing is that we've seen this, the outcome of the research, it's been picked up all over the world,
Yeah.
implemented very effectively in a number of different settings. And sadly, in the UK, I think we are lagging behind our successful implementation and consequent
Right.
benefit from that guidance. Yeah, there's a big issue still about inconsistency of the advice being received, and there's a big
Right.
issue around proper access to for those kids that come up with little bumps when they get tested, that need a food
Hmm.
challenge. They just can't get them, and if they can, it's not
Yeah.
in the time frame that means you can prevent the allergy. So, really frustrating.
Yeah, and what's fascinating is, correct me if I'm wrong, but I think that study was published in 2015. So we're
It
11
was. That's
years
right.
out,
Yeah.
and it's like we are just now within the last year or two really getting some publicity off of this, and it's like, oh, this new data, and it's like it's 11 years old.
Yeah, yeah, it's old news, and of course for
Yeah.
us, we were there in 2008, 2009, pretty much
Right.
knowing what the outcome of the work would be, but somebody had to, we had to get on and do
You
the
had,
study in
yeah,
order
you
to
had to do
prove
the
it, and it
study.
takes years because it needed all that long-term follow-up, and then it needs
Right.
publishing. So we were sort of operating, in that environment where we sort of knew, or at least thought we knew, but then were eventually able
Yeah.
to prove that early introduction was gonna be the key. Look, in 4 weeks' time, it's Allergy Awareness Week in the UK.
Right.
We are launching our national allergy strategy, which has been what's been keeping me very busy for the last year and a half, where we've
Hmm.
basically sort of pulled together all the different voices, the charities, the patient advocacy groups, the experts in education and healthcare and industry and food manufacturing and retail, getting everybody together to come up with essentially a single document to present to the government in all its different guises, saying, look, these are what we need as an allergy community to start making
Yeah.
life better. And a lot of it is around better access to specialist allergy services. A lot of it's about better public health advice, about easier access to not just OIT, we're talking about just sublingual immunotherapy for respiratory allergies, we're talking about biologics, all of these huge number of advances together with better food labeling, better
Hmm.
management of allergies in schools. It's a huge piece of work to try and just
Yeah.
start this engagement on multiple levels to just make life better for people with allergies.
Yeah, that's incredible. I love your perspective because in the US, we've got a good system, but it's also massively broken. There are certain strengths and weaknesses to our system. And I know there's a push and a massive push to go to a universal system. And I'm not saying one versus the other is better, but I'm
Yeah.
saying it's important that we talk, that we collaborate and understand, when we're asking for something or pushing for something, that maybe we also learn from the experience of others, and understand what those that are living it now, what that real life lived experience is, and maybe together as we collaborate, there a hybrid, is there something where we can learn from each other in those struggles and come up with a better product, ultimately.
Yeah. I mean, I'm absolutely convinced of that. I mean, what I've learned
Yeah.
through traveling a bit and often representing
Mhm.
my own hospital in other markets and other places that you know we all want to achieve high quality universality. Everybody gets
Mhm.
gets really easy access, and also a sort of comprehensiveness to sort of being able to offer a really broad range of everything. The truth is, no healthcare system has achieved all of that.
Right.
You guys have really done incredible things around quality. You've done incredible things about that comprehensive breadth of offer, but you
Yep.
really fall down on that universality because so many
We
people
do.
in your country just don't have access.
Yeah,
We
we
do
don't have we
fantastically
go
well on
without.
universality. You can literally sleep on the streets because that's all you can afford. Wander into an A&E department and find yourself, if you needed it, having an extraordinarily complex expensive operation, and your access will be the same as the guy who is hugely privileged and has all the money in the world. So
Yeah.
that's fantastic, but it consequently often falls down on comprehensiveness because you can't offer everything to everybody, and often will fall down on quality because quality takes resource.
Yeah.
And there is a finite amount of resource, and if everybody's getting access to it, so I always find it absolutely fascinating how the differences in the healthcare system directly impact on the way that we practice. And
Oh,
there's so many obvious examples. Eosinophilic esophagitis. You ask an American gastro how he manages it, and it's endoscopy after endoscopy after endoscopy. You ask a British gastroenterologist, and it's like you might be lucky to get one a year, and that's just the
yeah.
way that it's grown up because there just isn't the access to those things.
Right.
When you look at allergy, it's the same thing. You look at, I think the best example is look at the way we treat respiratory allergies, and in the US, very big on allergy shots. I'm going to say
Yeah.
something awful here, but maybe it's stayed the way it has for so long because you guys get paid per visit, so you're incentivized for people to come in and have their shot. Whereas in the UK, where our system is basically you're going to get paid, the hospital's going to get paid whatever it does, regardless of how many patients it sees, we're massively incentivized not to see our patients. So sublingual immunotherapy work brilliantly because we see them once, initiate their treatment, and they just go off and do it for 3 years and we don't need to see them again. So, simply because of the method of
A
reimbursement
method.
means that you end up with diametrically opposed ways of managing things. And I think one of my big worries, and I know we've chatted about this before, I worry the way that the US is going, not in terms of sort of, for your patients, but more because it's going to be so different to what the journey we're able to have in the UK around things like biologics.
Yeah.
They're expensive. And there's just no scenario in a national healthcare system that Omalizumab is going to be available widely for people with food allergy.
Sure.
It would be available if there were 50 people in the country with food allergy, but there's not. There's hundreds of thousands. So there's no scenario that we can manage it like that. And when I see what's going on in the US, I can see how this is now going to be diverging significantly from what we're ever going to be able to offer our patients because unless they can afford it out of pocket, and not many people are going to be able to afford biologics forever out of pocket, then we're going to start having differences in practice. That said, where there is a restraint in resource, inevitably that breeds innovation. And
Yeah.
that's great for us. We're going to have to come up with cleverer ways of doing things. And we've got some really exciting things coming up. In fact, we're about to open up our centre another one of those patch epicutaneous studies
Hmm.
for peanut desensitization. That's another modality that is going to need less visits, which of course is going to suit much better.
Yeah.
for our healthcare system, where we just can't have those number of visits.
Yeah, it's interesting the things you brought up. You know, Omalizumab, for instance, it actually. I'm the president of of a nonprofit organization, the Food Allergy Support Team. That you know that that's for the audience, and we do different surveys of our membership every year. And overall, amongst those allergists that are doing a lot of food allergy treatment in the United States, there's been a very slow uptake of omalizumab because of the cost, even in the States.
Yeah,
And we look at it as, first of all, as if you look at the FDA label and the indication as a monotherapy, it's not disease modifying. They have to continue to take it. And so for those of us in private practice in the United States, we still haven't taken that up very well. Where I find it useful, and part of this does also lend to our system in the United States, getting back to those system questions, is I still have the freedom to use it off label, and I can use it as an adjunct to
yeah,
OIT. That's actually where I found it helpful. And as an adjunct to OIT, they don't have to continue to use it. And so you have,
yeah,
even though it's expensive, you have a finite period of time by which you can effectively utilize that. Again, it's still been a really slow uptake because it's off label. There's all those issues, but it's fascinating in the case of some of the expensive biologics, again, how a system can drive certain things. Another one that I want to get your take on, because I think it's important, is Palforzia. This one was a peanut flour capsule, basically, for those that don't know, that was FDA approved in the United States, and it made a big splash because in the United States there are big marketing dollars, there are big pharma
yeah,
dollars, and so it was a big deal with our academies in college because there was a lot of marketing funding that was going into that, and so it made this big splash. But according to like our food allergy support team surveys, less than 5% of the allergists in the United
yeah,
States were using Palforzia. Why? Again, because of a system, we had the freedom and flexibility to be able to use real food. And we
yeah,
didn't need an expensive therapy. We could show that we can accomplish the same thing with real food. And it's been effective. We've done a survey where there's over 144,000 patients treated with real food effectively. But having said that, I think that this whole and now Palforzia is going to be taken off the market, not because of safety efficacy, because of sales.
yeah.
Um, to us, it's not that big of a deal, but I think it has different ramifications for the UK or for other systems. And I want you to speak to, that's our perspective, but what's your perspective, and how does that impact kind of what you're doing in the UK?
Yeah, it's a fascinating scenario. Although
Hmm.
it always makes me think of the headline that somebody once sent me from, I think it was the Atlantic, so a US magazine, that said, I think the headline was, "Only the American pharmaceutical industry can find a way to make a jar of peanut butter cost $4,000." And I'll be
That's the
honest, that's
American way.
exactly how we were viewing it. And it was,
Yeah,
we finally get this understanding of peanut OIT, and then in sort of classic sort of American fashion, it gets medicalized and commercialized in a way that is going to then dramatically reduce access for it. Now, we've got a big problem here in the UK that is very
yeah,
different to what your operating environment, because in the UK and lots of places in Europe, if a medicine is licensed by the equivalent of your FDA, so the MHRA, Medicines and Healthcare Regulatory Authority, if there is a licensed medicine, we cannot use an unlicensed medicine unless there is an extremely good clinical, can't be cost, clinical reason. Now, of course, that's a sensible rule, because as I say to
sure.
my patients who are always balking at it, I say, look, if you've got a infected finger and I say to you, you need a course of penicillin, but by the way, I've got a friend who makes penicillin at the bottom of his garden and I can sell it to you and it'll be half the price. There's good reason why I can't do that. I have to use licensed medicines. But when it comes to Palforzia, it's peanut powder. And I have to say,
Peanut
most of my patients never believed me about this. They
butter.
generally couldn't believe that there was a medicine that literally was just peanut powder. There was nothing, no
Yeah,
medicine in there, but it has
yeah,
been licensed as though it was a drug.
Yep.
And consequently, because it had its product license, now this was a very double edged sword, because on the positive side, if it weren't for Palforzia getting its license, it would have been extraordinarily hard to ever convince our hospitals to let us do OIT. Because otherwise, we're just a bunch of cranks who had this idea that we could do something special with peanuts, but it might kill somebody. So that was sort of like, whenever the hospitals want to do something, they want somebody else to have that liability. And once a product is licensed, then if there is a problem with it, it's not the hospital's problem, it's the licensing authority and the government for saying it was okay.
Hmm.
So on the positive side, they did a fantastic research program and they allowed us to get a foot in the door that started our OIT program. And had they not have done that, I genuinely don't think we set up a hospital called Great Ormond Street, very famous children's hospital. And I know that had we not have had that reassurance to give them that it was a licensed product, it would have been probably not been able to get it over the line. Once we'd started offering people Palforzia, and we were able to just say to their Drug and Therapeutics Committee, you know how we do that thing with peanut powder? We're going to do it with cashew and almond and sesame and all these other things. And that was fine because we'd already set that precedent. But we had this problem with peanut, which is there were these really expensive capsules, which meant that if you wanted it privately, it was prohibitively expensive, and we couldn't just do it with peanuts because that would mean using an unlicensed treatment when there was a licensed one available. And I know that in the US, you've got much more wiggle room to be able to do that, whereas we don't.
Yep.
Um, then this Palforzia product gets approved by what's called NICE, the National Institute for Clinical and Healthcare Excellence, which basically says we're not just saying that it works, that's what the licensing is, we're saying that this is health economically beneficial to offer through the National Health Service. So this is a huge event in the allergy world in the UK, because finally it means that there is a recognition that we shouldn't just, it's not that we could do this, we should be doing it for our patients. And we know there's about 140,000 peanut allergic kids in that age group. Everyone gets excited. The National Health Service put out actually a press release just before Christmas 2021 saying that they anticipate that we'll be treating about 1,000 children in the first year, and in the years that follow, 2,000, 3,000, 4,000 kids per year, and then puts no money at all behind it.
Wow.
Consequently, in the subsequent 3.5 years, under 100 children across the entire UK received Palforzia through the National Health Service. Far more than that were able to get hold of it privately, but they had to pay an enormous amount of money because we could only offer them Palforzia. We couldn't just do it with regular peanuts. So now we're a little bit sort of, when we hear this news a few weeks ago that Palforzia
Yeah.
is being pulled, it's sort of great. It means that we can just do this with peanut, but in the National Health Service, because there isn't an approved treatment, i.e., just peanut to use for peanut OIT, essentially all the people that were waiting for Palforzia, and it just at my own hospital alone, that was 450 kids on the waiting list,
Yeah.
they have all been told there's no longer support for this product, and we're not able to offer an alternative because there's nothing else that's approved on the National Health Service. At least privately, the price dramatically comes down because we're able to offer it without these expensive capsules,
Right.
but we're still stuck where we are. And in the National Health Service, even in the specialist allergy services, there's very, very little we're able to offer. And it's enormously frustrating. And with
Gosh.
my own sort of day to day, I've got a foot in, and the National Health Service got a foot privately. I'm finding that on a Monday morning, I'm seeing kids in a clinic where I'm saying, you've got this allergy, let's hope you grow out of it, but that's all I've got. But I'm knowing that if I just saw them in a different place on a different part of the week in my private clinic, I'm offering them potentially transformational treatments that, especially if they're little, are going to result in them eating that food freely within a year or two.
Yeah.
It's not great.
Wow. Systems.
Yeah, yeah, yeah.
Having to function within these systems.
Yeah,
And
and I think we're all the same. I think we all
we are.
just do our best to find the way. We just want to do the best thing for our patients, but the systems invariably, unfortunately, find ways to make that extraordinarily difficult.
It really is, and it's crazy that in a previous podcast I'd actually mentioned how you can look at so many differences and across the world, but there's unifying concepts, especially within food allergy or really any kind of disorder where the patients want the same thing and ultimately the doctors just want the same thing.
Yeah,
But we're having to both of us have to work within these systems, and sometimes when you're in a certain system and you see all the things wrong with that system, you tend to look at the other system. And it's like, oh, that looks, it's the grass is greener, right? And you look at the other
Yeah.
one and you're like, well, we want to move there, but at the same time, it's like we also need to understand what they're dealing with, and what
Oh
how
yeah.
they're having to perform within that system, and really kind of understand all the angles of it.
Yeah,
So
although your media have done a phenomenal job, a PR job on US medicine, which means that in the UK, and this isn't allergy, this is everything from cancer and diabetes and
mhm,
absolutely everything, that everybody imagines that US medicine is just better. And actually, when you think about where does that sort of come from, it's because we all watch Grey's Anatomy and ER and all these things, and you just imagine that's what it's like. And I've
yeah,
had some real wake up calls. I mean, not only when in
yeah,
my central London practice, I see a lot of Americans, and you sometimes sort of read the letters that they've come over with about their previous care. And you sort of think, really, there's
yeah,
some pretty funny things going on. And then having worked more closely with colleagues of yours, and we published an article a couple of years ago looking at the contrasting sort of the our future plans for managing food allergy in the UK versus the US, you suddenly
mhm,
realise that goodness, there's a lot of similar challenges in terms of once you get out of the major centres, suddenly there
right,
really aren't that many allergists. And it's really hard to access half decent specialist allergy care.
yeah,
That actually there are a lot of very similar challenges that we never imagine exist in the UK over there because we think you're just incredibly well resourced absolutely everywhere, and everywhere you go there's a full team of highly trained specialists that all went to Harvard Medical School because that's what it's like on the telly.
yeah.
So
Marketing. I would lend more
yeah,
towards Scrubs than Grey's Anatomy, but
yeah, yeah, yeah. I'm sure you're right.
uh, well, I've admired what you've been able to do within your system, and how you've been able to take a passion and the growth, and really grow a world renowned program for food allergy, and serving a massive need, in your country, in your community, with your extent. And what's kind of been your driving force, trying to overcome those challenges, overcome that system, and still deliver that high quality care to uh, the people in within your circle of influence?
I think there's always been a sense that there must be a better way to do this, and
Hmm.
from the beginning of my career when we first started, and there were very very few specialist allergy departments, and through the research that was going on, and a degree of I guess ambition from the hospital where I started working. I was always very very lucky at St Thomas's. We have alternate sources of funding that we're able to get through a charity that essentially belongs to our hospital. That's from a 500-year endowment, that sort of thing. We're able to develop a large specialist allergy service, build up a big research program, and create a model that we thought was really offering something really really good. And then as we'd achieved that, the specialty started to change profoundly. And it was becoming apparent that in our context, in that setting, we weren't going to be able to keep up and do what we wanted to do. And that really led me to sort of stepping a little bit out of that National Health Service into the more private sector, developing that again with actually the same colleagues, which is fantastic, and look at developing that so that we could create what we believe was genuine world class allergy care. But one of the key enablers for that has been the incredible spirit of collaboration that has been shown by clinicians all over the world
Yeah,
who are so open about saying, look, we're making advances here, so you can just join us on the journey. And Doug, look, this is something you should be enormously proud of. You have led this in the US. With a small group of you have got together hundreds of allergists in the UK who are doing OIT and created something really special, which is an environment where you can just speak openly. We know, look, this isn't, you're absolutely right, it's not an emerging treatment, but it is still in its infancy. And we all know
true.
we've got a million, I mean, every conversation you have, there's a million research questions that keep coming up. There's so little that that we know, but we know it works because we see it in practice all the time. And, it really, I'm sure it frustrates the hell out of you as well. The
Yes.
naysayers, the people that sort of say, oh, this is just so dangerous. What are you thinking? And it's like,
Yeah.
seriously, just come to the clinic, come and meet all of this army now that we've got of people who have graduated this treatment who will tell you themselves life is better because they've done this.
Yeah.
It's not hard to find these people. They're happy to shout it from the rooftops. The first thing I say when I'm starting to counsel someone about possible OIT options is let me connect you with another family who have done this. so that they can tell you from their non-medical parent perspective what the journey was like and whether it was worth it for them. And I don't have to ask for volunteers very hard because people love talking about it when they've been on this journey, which makes it so much easier for us to do that.
Yeah,
So,
and it,
it's that combination, that collaborative spirit, the outcomes that you see. It just makes you want to do better and do more of this. And just, I think for me, there's a little bit of a UK thing. There's always this sense that we just get a bad deal here. That if you're really sick with some obscure type of cancer, you're going to have to go to America to get the magic treatment because we don't have it here. And I've always sort of felt, that there was a time that London was probably considered the centre of the world, and it sort of isn't anymore. But you still want to think, goodness, people really ought to be able to access anything that you can get anywhere in London. That
yeah.
we really ought to be able to offer access to that, and it's our responsibility to work with people all over the world to make sure that people get access to the best possible medical advice and options.
Yeah, I think the center of the world is wherever you can make that impact with a patient. They're the center,
Yeah, maybe.
and we go around that. But that's amazing. Yeah, uh, really love the work that you're doing. Really have loved the collaboration. Um, it's crazy, when I think back 12, 13 years ago when I was starting it, like you mentioned, the naysayers and so many people saying, well, it's not a cure. Well, it's not. They would say everything it's not, and I would say, well, let's talk
Yeah,
about what it is, and what it is doing. And by doing, I mean, if we 12 years ago had said, well, it's not a cure, so let's wait, thousands upon thousands upon thousands of people would not have
yeah,
been, changed, had their life
yeah,
changed. And for me, it was always like, well, just because we don't withhold insulin just because it's not a cure for diabetes. We don't withhold certain things. We do the best we can with what we have. We collaborate, and that's always been my approach, is let's collaborate, let's learn from the patient, let's learn from each other as professionals, as clinicians, and let's pivot as we go along. Let's make sure that we're safety first, taking care of that patient, but we can do things along the way, and we can learn from this. And I loved your point earlier when you said there, anytime this comes up, there's 1,000 questions that come up, and it's like, right now, after I've been doing this 12, 13, 14 years, I probably have more questions now than I had back then.
yeah,
It's like
yeah,
the more you
yeah,
learn, the more you realize I don't know, and the more that I question, and the more that I want to know.
yeah,
But I'm so thankful for our groups, for our groups of professionals that share so openly, that collaborate so freely, because we do learn from each other. And I think part of the our food allergy support team group, it's just been refreshing because we have no pharmaceutical input, we have no industry. It is just us. It's allergists for patients, and it's been
yeah.
a beautiful thing to learn from. And it ultimately kind of led us to meeting, and hopefully we can do more with that. Or do you want to speak about
Absolutely. Yeah,
some of
yeah. I mean,
what you and I are
I've
planning?
Yeah, well, I mean, look, I've been spoiling to try and get this over in the UK and Europe because there's a huge demand, and there's a huge demand from patients because they want their doctors to be offering these treatments and these options. There's a huge desire by clinicians to understand more, but it's really hard because there's not many local experts in this. But that we're living in a global village now, so for me, getting sort of fast into Europe means that we can get people like yourself over to start, kickstart that journey, develop the local centres, and this will become a truly global effort, which is so exciting. I mean, there's so much expertise, but in all over the place, and such random places as well.
Yeah.
And just being able to bring that all together, and look, this is the power of the Zoom calls and the way that we work more closely since COVID. All of that, I think, has come together, and it feels very much like this is a coming together of a bit of a moment that, as a specialty, we finally go truly global, and being able to just widen the conversation, bring in all those other perspectives, it just accelerates everything. Because there's, however obscure that question you might come up with, whatever it is, there's always someone who knows more about it. And if you're able to reach those people quickly within that community, fantastic. Then
Yeah.
we're going to move forward really, really quickly.
Yeah, amazing. Well, I appreciate your perspective today. Thank you for your time. I know you're really, really busy. Admire your work and look forward to collaborating with you, uh, bringing this collaboration from the US to the UK, and like you said, taking it more global. So we're really excited for that. Just to close with this podcast, we part of it is about debunking myths and replacing fear with good information. And we call it edits or immune edits. And I would ask, what are maybe two or three things as you interact with patients day in, day out? What are maybe two or three misconceptions that people have? And what are those edits that they could make in their mindset or in their day-to-day actions that just could take them a couple of steps further in their journey?
I think, and I'm just thinking of just a clinic I've had today, there is so much to be done around mindset when it comes to treatments. And I'll be honest, I think that sometimes we've done a little bit of a disservice to our patients because of the fear that have been struck into them. And there's always sometimes a little bit of a tension that I think can develop around advocacy when we sort of have this horrible job that we need to highlight things to be taken seriously, which means we have to talk about food allergy fatalities, fatal anaphylaxis, these sorts of things. And we have to always remember what an impact that has on everybody who has a food allergy when you're talking about these things, because it brings it really close to home. And consequently, when we get into when we start talking about oral immunotherapy, and I've found this a lot, that our patients are so frightened to do this because they think that there is such a high chance that something catastrophic is going to happen, that consequently there's a lot of psychology involved, a lot of anxiety, and that actually really gets in the way of progress. So
Yeah.
I'm going to be honest, Doug, I've shamelessly ripped off an analogy of yours, which I often use, which is about the plane journey and the fact that if you're flying from London to New York, there's going to be turbulence on the way.
Yes.
But when you feel it, you don't immediately think, right, that's it, I'm out the door in my parachute, we've got to stop. You
Right.
just have to accept that anything worth doing, there can be bumps in the road. And that if you approach your OIT as saying, with no reason why we're not going to get there, we absolutely expect to get there. And yeah, there'll be some bumps in the way. And yes, there'll be some reactions and some might be unpleasant. But actually, there's no reason to think this isn't going to be a good outcome and we're not going to get exactly what we set out to do. Then if you can go into it with that mindset, it clearly makes a difference. And we've really seen the power of this mindset. And in fact, we've now taken up, we've got an excellent allergy psychologist we work with, and all of the people starting on our OIT programs now get a session with the psychologist before they start, just to talk this out, because so many of them have such ingrained fears, and we know where they've come from. It's understandable, and sometimes they've been horribly overstated risks given to them over the course of their sort of allergy career, that trying to unpack all of that can take time and it's difficult, but it's worth doing, because if you can get people in the right positive mindset when they go into a treatment, they're so much more likely for it to go well, for them to manage side effects well, and just get to the other side where everybody wants them to be.
Yeah, and going with that analogy, that nowadays you often hear the captain, when there is turbulence, you will hear the captain or the pilot get on the communication system and say, "We are navigating for uh, smoother air, and we will
Yeah,
adjust our altitude accordingly." And
yeah,
you go over all the emergency things before every flight. You have all the emergency preparedness so that you're not scared. But also, when it does come, the pilot, you, the doctor, are able to help that patient navigate to smoother air. And I love
absolutely.
that part. Like, you're not jumping out of it with the parachute automatically. It's just, no, let's troubleshoot, let's get to smoother air, and ultimately we will. We'll get to that smoother air and land. So that's great. Very beautiful. So thank you for joining us today. Any last comments? Anything else you want to share before we close?
No, just excited about the future.
Same.
Um, Also owe you a debt of thanks for organising an international meeting in Dallas 3 days before England play in the World Cup. There was no other scenario I was going to convince my wife that I could be in Dallas in the middle of June. So well done, thank you.
Well, I mean, I had in that planning meeting, we're like, okay, when is this happening? Okay, that's when our meeting's
Yeah,
happening.
yeah, I'm sure that's exactly
All right.
it.
Thank
Good
you.
stuff. Thank you.
All right. Take care. We'll see you soon.
Cheers.
Thank you so much again for tuning in. We'll see you next time on The Immune Edit. This show is separate from my clinical practice at Global Allergy Immune Network. This show represents my opinions and my guests' opinions. Neither myself nor the show endorses the views or statements of my guests. This show is for educational purposes only and is not a substitute for professional care by a doctor or other qualified medical professional. This show is provided with the understanding that it does not constitute medical or other professional advice or services. If you're looking for help in your journey, please seek out a qualified medical practitioner. It's important to have someone in your corner who is a trained and licensed healthcare practitioner who can help you make changes, especially when it comes to your health.